from other members of the community. We also have a Zoom presence today, so we'll be taking questions potentially from Zoom. Welcome to everyone who's tuning in virtually. Thanks for joining us today. Then her committee will retire to the next room and we'll have a private session that could last anywhere from an hour to 2 hours. And you all are welcome to hang out in this space if you'd like to afterwards. And that's how it's going to roll today. Now I'll hand it over to Dr. Lovette, who will introduce Brenda.
Great, thank you so much. I'm going to talk right into this mic so I can use my notes. Good morning, everyone. My name is Dr. Ruth Palin-Lopez. What a fantastic gathering we have today with a mix of esteemed faculty members, fellow students, cherished friends, loving family members, and let's not forget Brenda's incredible support system, including her spouse, Ty, her proud parents, Judy and Spencer. Your presence truly light up our room and make this day possible. I'm going to give you some credentials. Brenda's credentials. Let me introduce to you Brenda Lovette, a force of scholarly dedication and innovation. Brenda holds a master's degree in speech and language pathology from the University of North Carolina, and her Bachelor of Science in Communication Science Disorders from the University of Vermont. She is certified by the American Speech and Hearing Association as a licensed SLP in the Commonwealth of Massachusetts, and she's a certified brain injury specialist and a registered yoga instructor, and you will understand the importance of those certifications in a minute. She is also adjunct faculty here at the MGH-IHP and practices clinically at Emerson Hospital and at a private practice called Health Expression, which is a private practice specializing in gender-affirming voice therapy. During her tenure as a PhD student, Brenda's journey has been exceptional. She entered, endured, and succeeded in the PhD program, taking a different path. Rather than joining her mentor's research lab, she forged her own way. Brenda developed a mindfulness-based intervention, which she's going to tell you all about. Even before she began her PhD studies, she developed it at Emerson Hospital and brought it to the MGH-IHP. It propelled her to her PhD studies, and she studied the program as she was developing it and implementing it. So we have often used the term building the plane while flying it. Brenda's path has been defined by an unwavering dedication and fervent passion for advancing knowledge. She's pushed boundaries, and I'm confident that her presentation will captivate and inspire you. I urge each of you to actively engage, share your insights, and contribute. At the end, your feedback is invaluable. Once again, a heartfelt thank you for being here, and take it away, Brenda.
Hi, everyone. I'm truly so pleased to be here and share this work with you. Thank you so much for coming in person, everyone who braved the Boston traffic to get here, and everyone on Zoom too. I really appreciate the audience, and I'm looking forward to your questions afterwards. I have to, in particular, thank my mentors and committee members, Dr. Lopez, Dr. Lyons, Dr. Greenberg, and my academic advisor and chair, Dr. Townsend. So thank you so much, all of you, for your support. And thank you so much for the introduction, Dr. Lopez. As she mentioned, I began this work, some of the work that is involved in this PhD I did before I entered the program. And in fact, that's exactly what inspired me to apply for and yeah, my muting help over there. Thanks. Everyone on Zoom, please mute. Thanks. It inspired me to embark on this journey to become a clinical scientist. And like many clinicians, I saw a need and felt passionate to fill it, but I quickly realized to truly make my dream, have the impact of my dreams, I needed to embark on a rigorous scientific study. And so today I'll be sharing about that goal, about my learning process around it, and the proposed next steps to continue that work forward. So in this talk, I'll explain the significance of persistent concussion symptoms, the development of a mindfulness-based intervention to meet the unique needs of that population, and the rigorous approach that I took to study that intervention. Okay. All right. So I'll start with some background on this population, the concepts involved in this program of research, and then discuss the related contribution of this dissertation. Mild traumatic brain injury, also known as concussion, is the most common type of brain injury. And it was previously thought that symptoms would resolve spontaneously. However, more research shows that many people with mild traumatic brain injury experience persistent symptoms that last for months or even years after their injury. Persistent issues include somatic symptoms like headache, fatigue, affective symptoms related to mood, cognitive symptoms like issues with attention, memory, problem-solving, executive function, and sleep symptoms. And these symptoms and profiles all warrant rehabilitation. And indeed, there are clinical guidelines for medical and rehabilitation professionals to care for these individuals. However, for many, symptoms persist despite that care. The name mild might be a misnomer. As you can imagine, these symptoms have a significant impact on people's ability to participate in work, school, social relationships, daily function, and just generally have a negative impact on life satisfaction. The exact cause of persistent symptoms is not yet fully understood. However, age, gender, history of multiple injuries, all may be related. And most importantly, recent research has identified how psychosocial factors such as anxiety, fear avoidance, and other co-occurring or pre-existing psychological conditions or tendencies play a noteworthy role. So mindfulness is one way that we might support functional recovery for people with persistent symptoms. Before I dive into that, it'll be helpful to operationalize mindfulness here. Mindfulness is a state of mind, a perspective, and attitude. And mindfulness meditation is a formal practice that aims to foster or cultivate that attitude. A helpful metaphor I often use clinically is that mindfulness meditation is like practicing your jump shot, and mindfulness is the on-the-court application of that skill. Mindfulness-based interventions are programs that aim to foster trait and state mindfulness, and they have a broad clinical effect on a variety of aspects of health and wellness for both the general public and clinical populations. There's not one gold standard of mindfulness-based interventions. In fact, there are many types, and some of them are tailored to specific populations. Mindfulness practice is theorized to work through a set of psychological mechanisms that are listed here. And these components are distinct from each other, but interact, and to enhance self-regulation and ultimately result in improved well-being. Studies suggest that these mechanisms correspond with several key brain structure and function or neuroplastic changes in key brain areas, including those listed here. And current research seems to be focusing more and more on how brain systems work together, such as in the prefrontal cortex or the default mode network. And interventions that are delivered in a group might have additional mechanisms. Studies show that mindfulness practiced in a group may have amplified benefits, and this might be particularly important for those tailored mindfulness-based interventions where participants might be exposed to social support and coping strategies that are uniquely tailored to the shared disease experience. So I selected mindfulness as an intervention because, broadly speaking, research demonstrates that mindfulness improves cognition, pain, and mood and mental health, which are all common concerns among people with persistent concussion symptoms. And as I mentioned before, there's a growing appreciation for how anxiety, stress, and fear avoidance are associated with persistent concussion symptoms, and the research has demonstrated that mindfulness can positively impact these conditions as well. There is a small body of research on mindfulness specifically for TBI. In general, studies have shown a positive impact on symptoms and recovery. However, studies tend to feature small sample sizes. They're primarily conducted in research settings rather than clinical environments, and they broadly range in level of evidence spanning from early exploratory pilots to feasibility studies to a relatively small number of randomized controlled trials. In fact, there are 6 that we know of at this point. Additionally, the effects of these studies is hard to unpack and apply clinically for several reasons. One, studies look at widely different outcomes, and I'll discuss this at length when I describe one of our projects in this dissertation. And also studies include a mixed population. So often they do include people with mild traumatic brain injury and persistent symptoms, but they often mix in other diagnoses like stroke or moderate traumatic brain injury in the same intervention groups. Then also there's not one standard curriculum. Some of them are 10 minutes, some of them are 10 weeks, and they vary broadly in their ingredients and components. And importantly, to our knowledge, there are no programs that explicitly include rehabilitation principles in the curriculum. In addition to these gaps in knowledge, these interventions aren't widely accessible. They're just not happening in clinical settings. So there's a pressing need to first clarify the outcome assessments for mindfulness interventions, and then to develop an intervention that integrates mindfulness principles with neurorehabilitation principles while addressing those crucial aspects of implementation. And this dissertation aims to do that. So in light of those gaps and the needs, I went about developing a novel intervention that aimed to address all of these issues. I integrated principles of mindfulness with principles of rehabilitation at every turn. Alone, each approach, mindfulness and concussion rehab, has its relative strengths and also its shortcomings. Generic off-the-shelf mindfulness-based interventions might fall short of meeting this population's needs. So for one, these individuals often experience reduced activity tolerance, so lengthy sessions might not work for them. They also often have cognitive linguistic deficits, so the verbal and written instructions might be hard to understand. And then also the mindfulness exercises might not always be perceived as explicitly connected to the concussion recovery experience. Rehabilitation principles alone, while obviously integral to concussion management, often neglect that crucial psychosocial component that we know is so important for persistence of concussion symptoms. And then also, typically those are delivered in the individual format, which might be missing that potentially powerful impact of peer support. So this intervention curriculum integrates mindfulness principles with key concussion neurorehabilitation principles. And the principles, I forgot to advance. Oh, goodness. These are the principles here, and I'll go into those. I'm happy to go into those in depth later. However, we'll move along here for the sake of questions. Okay, 2 clicks. Okay, so in 2009, I developed a prototype of a mindfulness-based intervention group for delivery in a specialized concussion clinic. We titled it Own Mindfulness. And it included 8 weekly live video sessions, which included didactics, experiential exercises, facilitated small group discussion, guided meditation, and home program assignments. However, we weren't able to launch this in the clinic due to barriers related to the clinic structure. And in light of these barriers, I chose to launch the intervention here at the IHP in the Impact Practice Center. And in that way, we were able to also add the interdisciplinary graduate student support as well. So I want to actually thank Marjorie Nicholas for that idea, because that came from you. So I appreciate that way back in the day. So, namely, we had graduate students meet with participants weekly to support their participation using their rehabilitation skills and lens. This actually turned out to be more plausible due to the structure of the clinic in the university clinic setting. And additionally, this approach might be mutually beneficial for students and participants. For participants, the interventions might be more potent due to the additional rehabilitation support. And for students, it's an opportunity for them to practice mindfulness-informed rehabilitation with supervision. But this novel intervention has not yet been tested for feasibility and effect, and therefore this dissertation will pursue that objective. So this dissertation is guided by 2 frameworks. This first one is a theoretical model that I developed based on a review of the literature. So you can see that I'm theorizing that the intervention will lead to changes in the intervention target and ultimately improve concussion symptoms and quality of life. So we also left some space for some other unexplored elements in the intervention, which we aim to explore with qualitative techniques. And next, the second model that guides this work is the NIH STAGE model. So the NIH STAGE model for behavioral intervention development systematically guides the development, refinement, and efficacy testing and implementation, ultimately, of behavioral interventions. It includes 6 stages, which are distinct but iterative, and they emphasize mechanism of action at every stage to really enhance potency of the intervention. So this dissertation included 3 sequential projects, which I'll begin describing shortly. So the first project was corresponded with stage 0, that's basic science, and that is a scoping review that looked at the measurement techniques involved in the current literature. Project 2, it corresponds with stage 1A, which is intervention development and refinement. And this is a report on the formative evaluation of own mindfulness. And project 3 corresponds with stage 1B, feasibility and pilot testing. And this is an examination of the feasibility and preliminary clinical effect of the intervention. So we'll dive in now to project 1. It's titled Hidden Gains, and I'll explain a little bit more about that as we go along. And I'll take a moment to thank my co-authors at the Choir Lab at MGH. I'm so grateful to have had the opportunity to work with you and learn from you. And this project is complete and published in brain injury. And it lays a helpful foundation for the rest of the dissertation, as basic science will do. So as I mentioned before, there is a variety of clinical concerns for this population, and the research on mindfulness for mild traumatic brain injury is broad and varied in its targets. Understanding the measurement approaches for research questions like ours is helpful to more fully understand, first of all, the body of available research, and then also to make good choices about our measurement approaches in our studies. A scoping review is a useful systematic review for when the evidence is broad, not well-defined, and when the understanding of the field is in its nascency. So we included any longitudinal examination of the effects of mindfulness-based interventions for individuals following traumatic brain injury, any peer-reviewed studies and dissertations in English in any year. And I'll thank Jessica Bell for her help in developing the search terms and conducting the search. She is our medical librarian here at the IHP. And ultimately, we included 29 articles in this review. So for data extraction, 2 reviewers first extracted data from 20% of the studies. That was 7 studies. And then we met and compared our results until we came to consensus about what data we wanted to include and what those data said. And then once we came to consensus, we went on and each of us coded the remainder of half of the studies. And we ultimately extracted the following data to answer our 3 research questions. For question 1, we looked at what domains were assessed. So pain, mindfulness, executive function, depression, et cetera. For these data, we then organized them into broader categories or domains. And then for question number 2, we looked at what measurement techniques were utilized. So performance-based measures, self-report surveys, biomarkers, focus groups, and so on. We also looked at what instruments were used. So if depression was measured, which validated tool was used for that study. And then third, we looked at what the results of each were. So we collected where we saw statistically significant change in scores and effect sizes where they were reported, and also themes for the qualitative data. So this graphic displays our results. It was created by one of my co-authors, Milan Kanaya, so really helpful graphical representation here. And I'll guide you through the answers to each of our questions. So for question number 1, what clinical domains are being assessed in the research on mindfulness? That's shown in the size of the pie here. So you can see that cognitive function is the most commonly investigated area, followed by coping, general health, coping, and emotional symptoms. And you can see here how we organized sort of the subdomains within those broader domains. This was important because there was a great deal of granularity in these studies. For example, several studies might assess attention, but one might measure alternating attention, one might measure selective attention, another working memory. So we grouped those so that they were better understandable and applicable. We noticed that there was no quantitative and direct assessment of pain catastrophizing, which is a known predictor of concussion symptoms. There was no measure of physical function or disability or sleep. However, this did come up in the qualitative results. For question number 2, what techniques and instruments are being utilized to measure these domains? We saw that there were 5 different measures of quantitative assessment. Self-report surveys were by far the most common in all the domains except cognition, where performance-based measures were most common, and only in that domain. Additionally, some researchers use biomarkers, so heart rate variability, oxygen uptake, brain state measured by an external device. And a few use behavioral observations like head movement, medication use, and behavioral misconduct, which was done in a study of incarcerated individuals. And one study used friend and family report, and that was looking at insight. In terms of qualitative methods, there were 8 studies that used qualitative methods, 5 of which were mixed methods. And those scientists used focus groups, one-on-one interviews, and open-ended written responses. For question 3, what assessment domains and instruments are most impacted by mindfulness-based interventions? That's shown in green here. So overall, we observed some statistically significant improvements in each of the targeted domains, although none of the studies demonstrated statistically significant improvement in all of the studies that were done in that domain. The domains that significantly improved most frequently were coping, which included mindfulness, somatic symptoms, most particularly fatigue, emotional symptoms like depression, anxiety, and PTSD, and stress response. In terms of the synthesis of the qualitative findings, we observed benefits in essentially all the domains represented in the quantitative findings, plus additional areas and information that was beyond the scope of quantitative measures. For example, the ways participants were able to generalize these skills into their daily lives. So some noteworthy findings here. First, we may not be measuring the right things, which is this idea of hidden gains, right? So the most measured domains were coping, emotional symptoms, cognition, and general health, but the most improved were coping, emotional symptoms, somatic symptoms, and stress response. And although objective, physiological, biomarker, and neuroimaging measures were less commonly employed in these studies, and they mostly did not show significant change. Qualitative methods captured so much breadth and depth, but they were scarcely used. So some takeaways here: mindfulness-based interventions do indeed impact a range of clinical domains for people with persistent concussion symptoms, and they do seem to be best captured with a combination of measurement approaches, which set us up to move on to Project 2. Project 2 is a formative evaluation of own mindfulness. So at this point, we had run the prototype several times. Oh, thank you. Too many clicks. At this point, we had run the prototype several times at the Impact Practice Center. Before we went on to feasibility testing, we decided it would be useful to conduct a formative evaluation of the intervention in context to identify any areas of refinement. So thank you again to my committee here for co-authoring this paper, and also to Sion Kim Harris and Brianna Nicoletti. Those are 2 graduate student coaches who participated as graduate student coach clinicians in the intervention and stayed on to join me to engage in this as a scholarly project after they were done. And this paper is currently in the process of being revised. And after this dissertation defense is done, I'm excited to roll up my sleeves and take advantage of some helpful feedback for some reviewers to get it back into resubmitted. So we chose to use a multi-method approach to add depth to our understanding of the intervention and to also consider participant perspectives in our refinement process. We organized our inquiry into 4 questions. The first 2 here, participant characteristics and implementation, are quantitative, and the second 2 are qualitative, the participants' perceptions of the interventions and their perception of the benefits they noted. So we focused on 2 consecutive cohorts of the intervention. And at this point, the inclusion criteria was kept quite broad because it was an operating clinical intervention at the Impact Practice Center. And I'll mention here that I use my clinical connections to build a referral network of clinicians who are working with people with this diagnosis. And each semester I would email them a few months before we started and invite them to share information with clients who they felt would be appropriate or interested. And so that's how we were able to recruit our participants. So here's our approach for data collection and analysis. For quantitative data, we use surveys and observations to collect the data, and we analyze these data using descriptive statistics. So we had our intake surveys, which also did include one open text response, which we analyzed using content analysis. That was participants' goals and their referral sources. And then attendance logs and fidelity checklists, which were collected by a research assistant observing during the session. And then finally, focus groups. So for the qualitative data collection regarding the focus groups, this was the one element of the study which was considered human subject research by the IRB. So we did consent people for that part. The rest was deemed quality improvement, so we did not need to go through the IRB for that piece. Thus, while we invited all of our participants to join us for the focus groups, we didn't have full attendance for that. We had 3 individuals of the first group and 4 from the second. So we used hybrid inductive deductive thematic analysis to analyze the qualitative data. We had 2 analysts review 30% of the data, extract themes, and then met to compare their results until they engaged in an iterative process until they came up with their list of findings. So in regard to our answers to research questions, our research question 1, participant characteristics, we saw that most of our participants were white, female, and highly educated. This is consistent with some concerning trends in traumatic brain injury. While people of color experience traumatic brain injury at the same rate or higher as white individuals, we do see these disparities across the continuum of care. There was also a variety of time post-onset, and more than half of our participants were living with symptoms for over a year. And this is a population that's sometimes labeled as chronic and thought to be more resistant to recovery. But spoiler alert, we did hear from these participants that they perceive some benefit. And anxiety was prevalent in our sample, which is also consistent with research that emphasizes the prevalence and contribution of co-occurring anxiety with persistent concussion symptoms. So for research question 2, we saw good enrollment and retention. A few participants did drop out each semester for reasons that are common in this population, scheduling issues related to medical appointments and return to work, which is a great outcome, but that did cause the person to have to drop out. And those are unrelated to the intervention directly. And recall here that we used our referral network of clinicians to recruit people. So this result of enrollment and retention, I think, demonstrates both that this intervention is appealing to participants, but also to clinicians in the community who are looking for some such resources for their patients. We saw that attendance was good. About half of our participants attended all 8 sessions, and fidelity was pretty good, except for the home program assignment, which was only delivered explicitly part of the time. I will add that each participant got a handout and they were able to review home program assignment with their graduate student coach, but that was not delivered as part of the intervention. So helpful to learn that. In terms of research question 3, participants' perception of the intervention, overall, it was good. People felt that there was a positive impact on their life and recovery. They called it a gift, life-changing, and they felt that the format, structure, and content was just right. We also learned quite a bit from our qualitative analysis about their perceptions of barriers, facilitators, and how they appreciated many of the elements that were specific to this intervention, like the one-on-one coaching and the TBI accommodations, which are connected to those rehab principles that are integrated. We asked our participants for question 4, we asked them, what did you get out of participating? What were the benefits, if there are any, and tell us about it. So this was very open-ended, and participants indicated improvement in concussion symptoms and several key areas which were aligned with what we learned in the scoping review, and then some additional areas like hope and validation, reaffirming our suggestion that there are hidden gains. So there's some quotes here so you can get a sense for some of the ways that these people described these benefits. So in terms of self-efficacy for managing symptoms, one participant said, knowing that there are a bunch of different tools I can use was helpful. For validation, one participant said how important it was to be validated, that I wasn't crazy. Talking to everyone, just hearing that, oh, I'm not alone. That was probably the most important part of the whole thing for me, the support. And then another participant regarding hope said it gave them some sort of hope to get some sense of normalcy back. So some takeaways from this project. First, we found that the intervention was usable. It seemed to be a good fit and have value for the participants in regard to their recovery. So we learned a lot from this study and from our participants that helped us improve procedures. We saw there was some missing data, so we added some elements to our protocol to capture that. We revised the scripts to ensure full fidelity of the home program. And then we also went on to initiate more formal quantitative assessment of outcomes. And so our next step was to more formally evaluate the feasibility of intervention delivery and also begin that systematic targeted assessment of outcomes. Aligned with stage 1B of the NIH stage model, we then moved on to intervention feasibility testing. And again, thank you to my committee who have really had their hands in this project. This paper is currently under review. These are our 3 aims for this study. The primary aim was to determine the feasibility of the intervention protocol and the study protocol. And additionally, we set out to begin evaluating any preliminary signal of clinical effects. So given that this is a feasibility study with a small sample size and without a control group, these results should be interpreted with caution, but nonetheless, it's helpful to explore to see if we're going in the right direction with our intervention and with our study procedures and measurement procedures to prepare us for those larger scale studies. And then third, we also aim to explore participants' perceptions of any effects outside of the tools that we used. So this was a single arm, mixed methods, pre-post feasibility pilot study. We included 14 participants, again, recruited using that referral network. But this time we tightened up our inclusion criteria. This time we consented all of the participants and we excluded those with very long times post-injury and those who already practice mindfulness meditation or any kind of meditation to avoid confounding our results. So here I'll display our measures, data collection, and our approach to analysis. So the first we'll focus in on measures for aim 1, our feasibility aim. Here we measured enrollment, participant adherence, both with attendance logs, and this time we collected home program logs. So we were interested in how often people were doing the home program. And we also measured fidelity with the fidelity checklist. And this time we administered a client satisfaction survey at the end of the intervention. Oh my gosh, the clicking. And then next for aim 2, we measured mindfulness using the cognitive affective mindfulness scale. And we measured post-concussion symptoms using the post-concussion symptom scale. And we measured quality of life using the World Health Organization quality of life short form. And all of these are validated measures that have been used with this population. And then finally, for aim 3, we collected exit interviews from each participant to look at their perceptions of the effects and the adequacy of the measures. And we did those semi-structured one-on-one interviews and then engaged in framework analysis, which I'll explain in the next slide. So for our mixed methods analysis, we conducted this in 3 phases. We started with open coding, where we organized data in large discrete categories. In this case, we were interested in specifically the perceived effects. Then we engaged in hybrid deductive inductive thematic analysis. It was deductive in that our questions and codes were informed by the literature review, including the results of project 1, those categories we organized, and the results of project 2, the qualitative results that we obtained. And it was inductive in that we identified codes and themes directly from the data. And we also explored relationships between those themes. I'll share a helpful mnemonic here. So inductive in the data. So in case you need to remember that, I know that came up in another defense. So here, 2 coders went on to code 30% of the data. And then we developed a code book and engaged in that iterative process and moved on to develop our final list of findings. And so that iterative process where we got a lot of depth, especially in terms of the relationships among the findings. Next, we brought in the quantitative tools and we engaged in matrix coding, where we displayed the quantitative measures in columns and the themes in rows to identify where they converge and diverge. And I'll show you an image of that shortly. I think it's easier to understand when you see it. So here are participant demographics. So there were 14 individuals with persistent concussion symptoms involved. Again, they were mostly white and mostly female, mostly highly educated. We still had that spread of time post-onset, this time a little bit tighter without the very long post after 5 years. And here's a table of our results from AIM-1. So here we'll focus in, we chose a priori feasibility benchmarks using other similar studies in the field. And we found that, and as you can see, we met all of our benchmarks. Enrollment was excellent. Feasibility, fidelity, instrument completion, and safety were all excellent. The only one falling short of excellent was home program completion. So that met our criteria for good. And in line with common guidelines for feasibility studies, this study evaluated trends in the effects and associated effect sizes for our clinical outcomes. But again, statistical significance should be interpreted with caution for the reasons I described earlier. We did find a change in the hypothesized direction for trait mindfulness with a large effect size, concussion symptoms with a moderate effect size, and a smaller effect on quality of life. And these results, while preliminary, show promise, particularly in light of evidence showing that persistent concussion symptoms tend to remain stable, and that common non-pharmacological interventions for this population often fail to yield symptom improvement. So you can see our box plots here with the means, with the medians displayed and the data spread. In response to the open-ended questions about their perceptions of the effects of the interventions, all the participants described meaningful effects in multiple areas. And we observed this to follow a distinct pattern. So first, they reported a set of interconnected positive experiences as a result of the intervention. So they reported feelings of validation. In fact, every single participant indicated that. Also compassion and self-compassion, improved self-awareness, which then led to improved self-efficacy with symptom management. So this kind of sequence of steps seemed to really follow this pattern where being validated, seeing people feeling like I'm not crazy, help them to have compassion for others and for themselves, which help boost self-awareness, which then help them to use the strategies to manage their symptoms and participate in their life more. And this appeared to serve as a catalyst for 2 outcomes. One being the ability to acknowledge or face their situation, accept things as they are, which we labeled as resilience. And then 2, reduction in concussion symptoms. And ultimately, these positive emotional and outcome-related processes appeared to lead to enhanced life participation, social relationships, and quality of life. So focusing in on that resilience outcome, because it was one that we didn't anticipate as being so meaningful, and also really brings their experiences to life. Participants described acknowledging, I'm not where I want to be, but I'm able to take a breath and see, okay, there are areas where I'm better or where I'm making progress. They described finding that acceptance piece. I know I can't go back, so I can only go forward. and feeling that the tools are making my life a little bit better or allowing me to partake in my life a little bit more. One participant described, "I didn't have hope before. I felt like I was in a tunnel that had no space, no room, and no entrance or exit. That's what I felt like. I don't feel like that anymore. I found a new way." They described how this resilience helped boost their life participation and overall quality of life, which is ultimately exactly the goal for us in all of our rehabilitation work. Our framework analysis confirmed that our tools captured several benefits that the participants described. For example, reduction in concussion symptoms, including somatic and sleep symptoms, cognitive and emotional symptoms, and the changes in quality of life. The HUQUAL also provided some indication of social relationships, though indirectly, and the framework analysis demonstrated that none of these quantitative tools measured validation, compassion, self-awareness, self-efficacy, resilience, and life participation. So, as a takeaway here, the study design did meet all feasibility benchmarks: enrollment, retention, adherence, fidelity, instrument completion, and satisfaction was good. There were no adverse events, and a change in clinical outcomes was promising. The qualitative results yielded a model of functional recovery that included outcomes like resilience and life participation, and several interconnected constructs that warrant further exploration. And qualitative results also highlighted validation as a critical factor, which suggests it would be useful to control for group support in future studies. Oh, goodness. There's that slide. It's not as pretty as the other ones I skipped. So for future directions. So in summary, we were able to rigorously evaluate a clinical initiative using guidance from the NIH stage model. So first, study 1, the scoping review aligned with stage 0 basic science, affirmed the efficacy of mindfulness for persistent concussion symptoms, and told us that studies should use a variety of measurement approaches, and future research should include some of those underexplored outcomes. Study 2 was the formative evaluation, and we saw that own mindfulness achieved good engagement and fidelity, and participants perceived meaningful benefits, and results informed improvements to the intervention itself and the research plan. And then finally, project 3, this is aligned with stage 1B. This met feasibility benchmarks. There was a signal for improvement in clinical outcomes. And then the framework analysis suggested additional areas to test. And the qualitative results suggested some interesting relationships among the outcomes. So there are implications of this work for several areas: practice, education, policy, and research. So although we don't yet have sufficient evidence to support the widespread adoption of own mindfulness yet, there are some useful implications for practice. So one, we know that mindfulness strategies could be useful to support recovery for this population. So beginning to integrate that into clinical practice could be useful. And then also incorporating validation and these other positive experience into our care, because we heard from our participants that they perceive that these catalyzed their other functional recovery. In terms of education, if we want to incorporate mindfulness-based approaches in care, then this should start in the education setting, so including training for trainees at the graduate clinician level. And then in terms of policy, given that the establishment of efficacy of these interventions, stakeholders would want to work towards securing insurance coverage for mindfulness-based interventions. And finally, there's several implications for research, which I'll describe here. So Project 3 confirmed the feasibility of intervention delivery. Next, we would want to move to stage 2 of the NIH stage model, which is efficacy in the research setting. So before large-scale efficacy testing, we must first develop and test the feasibility of our research plan. So you can see here, I proposed this pilot randomized control trial with these 2 aims. First, to determine the feasibility of the randomized controlled trial study protocol, and then again to explore preliminary signal of improvement of outcomes. And for this study, we would include a control group, namely a support group with without any kind of mindfulness instruction. We would include that graduate student support, though, to control for the amount of therapeutic attention. And there are many options for control conditions, but since validation and group support seem to be such an important element to participants, this would be a meaningful place to begin. And regarding clinical outcomes, we would use the same outcomes that we used in study 2 or project 3, stage 1B, but then add additional measures investigating those additional constructs that we learned about in our qualitative analysis. So moving forward, our larger scale fully powered trial would explore directionality among these variables. There are several other areas for directions for research. In fact, I like to think of this project as a living lab. It's a place for academic kind of study and also training. So here are just a few ideas that I have. First, to more formally use the rehab treatment specification system to map our intervention components on this model. So there's an image here of the model where you can see where ingredients and hypothesized mechanisms of action result in targets. And this would more firmly ground this in the rehabilitation space. Next, to look at how a mindfulness intervention fits into standard rehab. So, our participants talked about, they were all involved in other kinds of rehab. And so it'd be interesting to see how those interact with each other, if the mindfulness intervention helped them benefit more from their physical therapy sessions, for example. Also, it's really important that we investigate the root cause for the limited diversity in our samples. It could be referral bias, it could be selection bias. Is it something about our marketing or recruitment? Is there something that we should do to make these interventions more accessible to diverse groups? And lastly, I'm eager to study the graduate student clinician component, and I want to thank Bonnie Halverson here for her involvement with this part of the intervention. She was just, I couldn't have done it without her. Also Sarah Rossmassler for being clinical education champions. And I think that we have that in our future to look into this a little bit more. So that's all I have for you, some acknowledgements. So my heartfelt thank you to everyone who helped make this possible, my committee members, co-authors, my mentors here at the IHP and beyond. I actually emailed my undergraduate thesis advisor this morning and told him I was defending, and he was so thrilled about that. Dr. Canizero at University of Vermont, of course, Dr. Nancy Helm Estabrooks, who was at UNC when I was there for my master's degree. Also my clinical education champions, Bonnie and Sarah, and the graduate student coaches who I was just so impressed with their care and thoughtfulness and growth in the program. And the participants themselves were so vulnerable with us, and my friends and family, some of whom are here, and all of my mindfulness teachers. And I always like to mention my cat, Clarissa, who is my most important mindfulness teacher. So thank you, and I'd love to hear your questions. No.
Switch. It's all the way down at the base.
How many PhDs?
I know, right?
We need like little nails too. No, okay. You can talk loud. I can repeat the question. I'll take the first question and yeah, Amber.
Thank you, Brenda, for awesome presentation, and I'll let you field the
Thank you,
questions.
thanks. Yeah.
Can you hear me?
Oh, yeah. Okay, good. All right.
Brenda, that was a beautiful presentation, and it
you.
was so great to see how your work developed over time. So thank you for sharing. I think it's really a cool thing about this program, how we have so many clinicians with experience come back and it informs their research. So I was just wondering if you could speak a little bit to how your experience as a clinician came into your intervention development and implementation thoughts.
That's a great question. Thank you, Amber. Yeah, I mean, there's so much that happened before I began this, even developing the intervention. And it started, I mean, this was probably 10 years ago. I had a friend that was more in the kind of like counseling, honestly, metaphysical space, who was doing a lot with mindfulness and meditation. And I remember saying to her, I really wish I could be in that space more, but I'm in healthcare, so it'll never happen. You know, I can never bring this into my work, even though I see how it could benefit patients. And then I just started doing it and seeing the impact that it had. And, you know, of course, that anecdotal evidence is not something you can really hang your hat on, but it is what planted the seed for this work. And just trying it and seeing how individual people sitting across from me in the table actually responded to it and becoming more curious and asking them questions. So it really is grounded in human beings, which is something I love about this work. So thank you. Yeah.
Lovely job, Brenda.
Thank you.
I actually have two questions, but they're kind of related. So the first one is thinking about the lack of diversity in your sample. And I was really struck by the fact that it's 90% women. So what are your thoughts for why that is the case?
Yeah. So I mean, going back to this was more about race, but the diversity among people who get care for TBI, I think that there's something about gender there too, that I think that in our culture, unfortunately, more, you know, masculine identified people are not seeking care for things. I do think that I'm seeing this less. It used to be that I would suggest a mindfulness technique in a session and the dudes would be like, no, but I'm not seeing that as much. There's a lot more openness to that. I do think that there is a little bit of evidence that women have, you know, tend to have more persistent symptoms, although maybe that is more related to reporting too. So yeah, I think there are several reasons. And then also, yeah, the research on mindfulness tends to include more women as well. So it's a great question. Yeah.
So relatedly, I guess this is what, you know, I'm a psychologist, so this
Yeah.
is what I'm thinking about. So, you know, we know there's gender differences in therapy and gender differences in depression and anxiety, but you don't measure that in your study. And so I'm wondering, especially with 90% the sample women, 14 sample size of 14, even if a couple of those women are getting therapy, what do you think might be going on? Like, do you think that could be accounting for some of your findings, is that you have kind of overlap between mindfulness and psychotherapy that could be potentially impacting your results?
Yeah, I mean, I have that. I actually don't think I have that on one of my extra slides, but we do have data on what other interventions these people are in. They're not in therapy. Mostly, like one or two, but it's not that, and that is another gap in our, you know, this work intends to fill that gap of these individuals probably could benefit from therapy, but they're not receiving, you know, counseling. But it's a great question. I think it would be really interesting if we had more participants to kind of get into more of those differences. Yeah. Yeah. Thank you. Yeah.
Brenda, congratulations. You made that presentation look like it's just been this smooth, easy, quick little journey through these different stages. And we know that this is the illusion for
Yeah,
all of
it's
the
illusion.
PhD students in the room, that it doesn't, that's not the reality, but it's really nice that you packaged it all up to look like such a
Yeah.
lovely, neat, tidy little thing. My question is about the active ingredient. So it seems when you looked at the qualitative statements, like the validation piece, I'm not crazy, there's other people that are like this. Maybe it was just the selection of what you presented, but it seems like that was a really prominent active ingredient. But what do you, and I was like, I like to see your hypothetical, like, next study
Yeah.
would be studying that explicitly as a control. But what do you think the active ingredient was for your?
I mean, this has come up throughout. It's like, is it the group? Is it the mindfulness? And, you know, if we teach people to practice mindfulness alone in their home, is that the same? From this model, I think helps address that question. It's all of it. It's the combination. And I sort of alluded to that when I described how people said, feeling validated help them to then engage in these other ways without that validation. And I see that in the clinic too. Like if I'm telling someone, you should be compassionate to yourself. And, you know, that's kind of coming from a clinician to someone who's, you know, their life has fallen apart because of their injury. It doesn't mean the same as having another person who's experiencing that same thing and sort of like, oh, if I can be compassionate towards this person, then I can do it for myself. And then ultimately I can use rehab strategies. So it did seem connected. So I think that I'm really interested to see if support groups can be really great. And also in the brain injury community, there's a little bit of a negative kind of stereotype that they can be kind of a place to go and complain about your providers or about your life or something. So I think that this kind of strength-based, the mindfulness tools that are then applied outside has there's a special sauce there.
It might be interesting in your ideal strategy to have 3 groups where the third group is getting the individual based mindfulness, then you could like tease out
Yes,
which they act.
I would, yes, I'm looking for funding for that. So would love it. Thanks, Tree.
All right, I'm not sure. Oh, maybe the juices.
All right.
Yeah.
All right. That was awesome. That was a really great presentation, Brenda. Thank you.
Thank you.
I've kind of follow up to Annie's questions about kind of recruitment in your population. I think one piece is we know from the military background at service academies, there's been a lot of work on non-disclosure of concussion symptoms in that group, which is heavily male dominant. So I think that is definitely relevant. But for the anxiety that you had noticed, was that pre-existing to the concussion, or since they'd had chronic concussion, you think some of them developed it as a secondary to that diagnosis?
That's a great question too. So we did ask that, and Jonathan, this is Jonathan's research as well about anxiety and concussion. We did ask that question. We tried to. This is all self-report, so it'd be great if we could have access to their Epic chart or something like that. But we saw there was some and some. Some people had pre-existing anxiety. Some people had anxiety that emerged after their injury. Some people, and we hear this a lot from patients and from research participants in a study that we did recently, that they might have had anxiety, but then it was just completely magnified. So there's something really interesting going on there as far as how anxiety interacts with the injury. Yeah. Mm-hmm.
That makes sense. And then for your recruitment, was this through rehab that they were already getting, or was this through like their PCP?
Great question too. So that is also data we collected, but I didn't present here. They were mostly their therapists, so mostly PT, OT, speech. These are like clinicians I know in the community and their networks. And so I would often kind of tell them verbally, this is a great option if you're discharging someone, they're not better yet. You know, this can help kind of bridge that gap, because there is that kind of crisis that happens in outpatient clinics where when you discharge and you're like, good luck, sorry, you're not better yet. So, so this is, you know, the clinicians were really eager for this. And I keep getting emails even now, when's the next one happening? So again, that funding, but yeah.
That's awesome. Thank you.
Thank you. Yeah.
Thank you. Bravo, Brenda. That was a wonderful presentation, program of research, and the program itself seems fabulous. Not to harp on this issue of the homogeneous.
Yeah, I know.
family
I
dynamics,
know.
But I appreciated your thoughts about how to improve access to the program, to tweak how you're recruiting participants. I'm wondering, given your clinical experience, given what you've seen in the literature, are there adaptations to the actual program that you foresee needing to make it salient for the dudes, or to reach the minority populations that I think need to be included?
Yeah. So one of the participants, this happens so organically, which I love when this happens. One of the participants in the exit interview, she's a woman of color, and I have to really pull. I'm like, what else can we improve? What else can we? She was like, well, there's one thing. And she said she had actually found guided meditations in the voice of someone who sounded more like her. And that was valuable to her. And so I was so grateful that she shared that, because I didn't specifically ask. So I do think there could be things that we make, that we do. One thing that I did, and this was a clinical decision, not a research decision, when I was pairing graduate students with participants, if there was a male graduate student who was male identified, I would kind of hook them with the one male in the group. And I would personally go to at least one of each of these coaching sessions. And I did feel like that was useful. So if I knew anything about participants, I could kind of slightly cater that to the individuals. But also to that point, which is not your question, but it was really just so sweet how each participant felt like they were matched with the perfect coach. They were like, I loved my coach. I'm so glad I got them. And I'm like, well, you might have felt that way with any of them because they're great, but I'm so glad. But anyway, back to your question, I do think that would be really interesting to look into. Mindfulness is not intended to be culturally connected but people do come obviously with their background, preconceived notions and experiences and needs. So it would be a good thing to look into.
Yeah, great thoughts.
Yeah.
You think down the road, is there potential for peers to deliver this kind of intervention?
Maybe, yeah, that would be awesome. Yeah. Yeah, we can handpick some good ones.
You can have the last word.
Yeah.
Brenda, just fabulous job. It was so interesting to hear all of your studies. I have a question that's about, now that you've embarked on qualitative analyses and became more expert about that, I have often wondered, now that we know about ChatGPT and AI, what your thoughts are about the usefulness for that, especially for qualitative thematic analyses. Have you and your research team, I imagine everybody's talking about this. So what are your thoughts?
I don't know if it's good enough yet. I would be interested to hear what you think, Dr. Lopez, but I think, from like, it just doesn't always get the humanness of the connections of what's there. It could get to that point, I suppose. I think it would always be important to have human scientists checking whatever ChatGPT spits out, just to make sure that we're on track. So yeah, I don't know. Do you have any thoughts about that?
Yes.
Another hour.
But I'd have to look it up on ChatGPT so I can put it into words that sound coherent.
Yeah.
I love ChatGPT.
Yeah.
I don't trust it yet.
I just read an article about using it for
Qualitative research. And
Yes.
yes, and it makes up quotes. Like even if you give it text,
Oh.
it spits back quotes that are not.
It's like, you meant this. It's like, that's not what I meant.
I would.
So maybe not there yet.
Bias in the same way that you.
Yeah.
Yeah, so that part it's okay for, but like if you ask
I
for
wanna
like
answer your
quotes.
question.
it
I
would
wouldn't
make
do that.
up- Yeah.
Can I have one more question? Just one more?
One more?
Yeah, just one more.
Let me check with your
Like
chair.
Yeah.
Can she have one more question?
This is the fun part. Yeah.
Thank you for giving me.
Oh, here we go.
My question is somewhat related to technology, so it's somewhat related to this conversation that we started. I'm curious if you gave any thought to the use of screen time within this population, knowing that reducing screen time is an important part of recovery. How did you rectify or even just manage that balance?
Yeah, thank you for asking that question. So yes, it is not true that screen time is detrimental for people with concussion, and that's a misconception. And one of the things that I'm glad I'm on the right slide here too. One of the big pieces that we integrate in the program is the accommodations. So teaching people to use accommodations specifically for their symptoms. So the coaches and throughout, we always said, if you're experiencing symptoms because of the screen, turn it off, look at the wall. We taught people how to do that. So in theory, it was a way to treat that decreased screen tolerance using confrontation strategies in the setting of this actual activity. And then we asked people about facilitators and barriers, and some people said technology was a barrier. They said that it didn't work all the time, they had issues with it, and many people said it was a facilitator. So we had participants tuning in from France and Colorado and Dedham and Stoneham. So, that wouldn't have been possible in person. But it's something that's kind of embedded in the work. So yeah. Okay.
So thank you all very much for coming. I also wanted to give opportunity to your support team if you wanted to ask any questions or any comments. When my chair did this and handed it to my 7-year-old son, I got really, really nervous.
Well, no, I think Janet's represented us.
Yeah.
Thank you.
So at this point, I think the committee will convene with Brenda and we will be back.